history of hospital admission with recurrent loss of consciousness, intermittent irrelevant talking, and aggressiveness with undue exertional fatigue and atypical chest pain for last 3 years. According to the statement of attendance, she had history of complicated delivery with significant postpartum hemorrhage during her second childbirth 3 years ago. Since then, she is amenorrheic and agalactoric. So over the first five months, she had unexplained weight loss of 18 kg has been verified through the changes in clothing fit and reading on his scale. During the tenure her illness, she was hospitalized in different private hospital clinics, also in government hospitals. At recent past, she had prominent complaints of atypical chest pain and exertional shortness of breath with above symptoms. On physical examination, she was drowsy, malnourished, cachectic, and non-cooperative. Blood pressure 90/60 mm mercury, heart rate 100 beats per minute, respiratory rate 20 breaths per minute, reduced breast enlargement with moderate anemia, and she had also dry, coarse skin and hoarse voice. Other systemic examination revealed nothing abnormal except in central nervous system examination revealed little bit drowsy, poor response to the oral commands with delayed tip tension jerk. So though patient is admitted in different times in different level of hospital, so patient had done different investigation. I will summarize the investigation. Sorry. So complete blood count, this is persistently low hemoglobin 9 gram per dl, and random blood sugars 4 millimole per liter, it is initially low, and electrolyte, this is the most pointing parts of these presentations. She had persistently low electrolytes, that is low sodium level, that is 126 millimole per liter, other potassium and chloride is normal. So there is a hormonal profile, there is serum ACTH level that is also hitting low 3.21 normal, FSH, LSH, serum prolactin and serum cortisol levels and serum TSH, all the hitting are low levels, 0.20, 0.40. This is the all pituitary hormones are low levels. So there is a copy, we have done some investigation before coming to my patients to the different hospital. When see the sodium also reduced in 132. In my private health clinic, there is also sodium is low 126, serum ACT also reduced 3.12. So there is other hormonal profile, estrogen level, luteinizing hormone, serum prolactin level, and serum TSH also hitting the low levels. So CT scan of brain is done in other private hospital, though it is normal, CT features are consistent with normal limits. So patient repeatedly complains atypical chest pain and exertional shortness of breath. So we have done ECG. ECG showed low voltage ECG with T wave changes, with chest X-ray showed mild cardiomegaly with negative troponin levels. And transthoracic echocardiography showed regional wall motion abnormality, mostly interseptal wall with LV IDD 58 millimeter with LV function 50%. So there is a still picture, there is a LV IDD increased and there is also regional wall motion, then there is a T wave changes in ECG, and also there is low voltage. So on the basis of imaging, electrolytes, hormones and hematinics assays demonstrated low levels of hemoglobin, TSH, serum cortisol, ACTH, prolactin, hyponatremia, and chest X-ray cardiomegaly, and echocardiogram revealed regional wall motion abnormality, assuming the diagnosis of Sheehan's syndrome with possibility of ischemic heart disease. So after admission, patient though low BP, so her hypertension worsened and required inotropic support with fluid support, the loading dose, antiplatelet, non-epinephrine, and hydrocortisone. And after giving this, patient is stable. She was giving 2 units of blood transfusion, though patient persistent low hemoglobin level. And that time, he was patient given oral hydrocortisone, anti-ischemic medications, and low dose of levothyroxine. And after this medication, patient was improved. And 7 days, she was asymptomatic and discharged with prescribed medications. So here we try to explain the clinical case. This young lady, 36-year-old lady, having 2 distinct non-communicable disease, panhypopituitarism, the Sheehan's syndrome, with ischemic heart disease. Though this young lady having no previous history of hypertension, diabetes mellitus, valvular heart disease, or rheumatic fever for developing heart disease, but I try to relate this pan-hypertrophy can relate to the development of ischemic heart disease. So reading the journal, I have found that this make precise assumption of the hormone mechanism responsible for the premature atherosclerosis. So low level of these pituitary hormones can develop the premature atherosclerosis. This compelling evidence for a reduced life expectancy from the premature atherosclerosis in the hyperpituitary patients. This mechanism for this are complex and multifactorial. In this context, long-term prospective randomized control trial is required to establish the strong relationship between two cases. So this case emphasizes the intricate relationship between the hypopituitarism and ischemic heart disease. The hormonal imbalances associated with pan-hypopituitarism can contribute to the cardiovascular complications. The successful coordination of the hormone replacement therapy and cardiac intervention can significantly improve the patient's overall well-being and reduce the risk of the further cardiovascular events. So this is my great limitation. MRI brain and coronary angiogram could not be done here to confirm the pituitary epilepsies and ischemic heart respectively because the economic issue is very concerning here. So after discharge, patient did not come to the hospital for next follow-up. Thank you for patient sharing.
Okay, thank you, Dr. Nazmul Haque. I think it's the time for question answer, and question should be invited from the chairpersons because it's a co-petition. Honorable Chairperson, if you have any questions.